All right, everyone, please find your seats. We're going to get started with building your care team. Okay. Coming back in the room. All right, well, during this session, they're going to be, it looks like they've gotten most of the silverware down, but right at noon, they're going to be serving lunch. So if we're still going at that time, just please try to listen, and they'll be bringing the lunch out. So without further ado, I'm going to hand it over to Meghan Malley.
Thank you, Kristen. Thanks for having me. Today we're going to be talking about building your care team. And so I'm going to start us off. I am Meghan Malley. I am a physical therapist by education, and I have been practicing in neurological rehab with a focus on Parkinson's disease for 15 years. And I'm the program director at the Recovery Project, overseeing the development and implementation of all of our medical and wellness programs. That includes our Parkinson's disease program that serves over 400 individuals with Parkinson's every single year. So today we are going to just be touching on why it's so important to have a care team, who should be involved in your care team, and what their roles may be. And the importance of this is that, as you probably already know, that you might have a variety of different symptoms and issues that present themselves when you're living with Parkinson's disease. So it's important to have a variety of experts on your team to help you address each of those needs. And this might be something that changes over the years as a disease may change or progress, or you have different needs. And so there's a lot of individuals with great expertise in different areas that can help you out. So to have those resources and to have a comprehensive team approach to help you manage your Parkinson's disease is ideal. So who might be on this care team? And the list could be quite long, so just going to hit some of the more common members of the care team when you're living with Parkinson's. And one being your neurologist. So of course you want to make sure you have a trusted neurologist on your care team, and in particular a movement disorder specialist. So that's a neurologist who specializes in movement disorders such as Parkinson's disease. And then, of course, selfishly, I have to go next with physical therapy. So I would love to encourage everyone to have a physical therapist on your care team, specifically one who has a great understanding of neurological diseases like Parkinson's. That's quite different than a physical therapist who might treat more sports and orthopedic-related issues. The same goes for an occupational therapist, and they're an important member of the team, and Brian's going to be touching on that after me. Same with speech language pathologists, which AnnMarie is going to be discussing. That is another vital piece of the care team. And then members such as a psychologist or a social worker, a counselor, someone that can really help deal with some of the psychosocial changes of living with a chronic illness like Parkinson's and how things might change in your life, such as your roles, your ability to participate in things that are meaningful to you, and family dynamics and things like that. So having a resource on your team in that area is very helpful and recommended. Another member of the care team that can be very beneficial is a dietitian or a nutritionist. So especially if you're having issues with your diet, your nutrition, your GI system, losing weight, things like that, that's another helpful member of the team. And then, of course, you and your care partners. You're the most important members of the team and are, encouraged to be your own best advocates when living life with Parkinson's, and really steering the ship here as the CEO of your own health. So I'm just going to go into a little bit more detail about the role of a physical therapist if you haven't seen a PT for your Parkinson's disease and may not be as familiar about what we can offer. And we are really the experts in movement and exercise and mobility. And especially for individuals living with neurological diseases, that is really our specialty, to assess how you're moving, what challenges you're having with day-to-day activities and with function, and really create an individualized plan for you to really meet your goals, keep you safe, keep you active, and enjoying the things that matter to you in life. So that could really range from things like working on your balance, working on transfers. Maybe you want to get up and off of the floor because you want to play with your grandchildren, or rolling in bed. We know that can be a struggle and something we used to take for granted. And how about stair negotiation? You have a bunch of stairs that you need to deal with and are feeling unsteady on. Or walking. Maybe you're fine walking inside, but you want to enjoy walking around in your neighborhood with your family, and it's uneven pavement and things of that nature. Or maybe you're really active and you love doing things like pickleball or other activities, and you want to stay strong and healthy and be able to do those things that you enjoy. How can we help you in physical therapy keep you strong, active, safe, and on the top of your game? So we really have an in-depth understanding of how Parkinson's disease affects not only your motor system, but your potentially cognitive system, your sensory system, and just all throughout your body, and how that impacts your overall function. So that's why it's important to seek out a physical therapist who works with people with Parkinson's and works in neurology, so that they really understand the full picture of what you're dealing with, and things like what medications you're taking and how that may affect you at different times of the day. So in addition to creating individualized exercise plans, we also do a whole lot of other things that can be really beneficial and helpful for you. So that might be providing education and training and just information on the disease process itself. We're really fortunate in therapy that we get to spend usually a lot more time with you than your neurologist might be able to. So, for us at our clinic, we have 1-hour appointments, and we're usually seeing people with Parkinson's a couple times a week. So that ends up being a lot of time that we get to know you and your family, get to have chances to give you more education about the disease if you have questions or wondering why you're experiencing something, and is it Parkinson's or is it not, and is there anything that you can do about it? So we give a lot of education about the disease process itself, how it affects the brain and other body systems. We also provide a lot of education and training on various assistive devices. So that may be something you need or maybe not, depending on how you're functioning and how the disease might change over time. So we have a lot of knowledge on different tools and different devices that might help you stay as active as you wish and keep you safe and independent. We also provide a lot of education and resources to not only the individual living with Parkinson's, but also their care partners on topics such as fall prevention, home safety modifications, what's available for even car modifications, things like that, to really look at the whole picture of your life and how Parkinson's might be affecting you in different ways. And then lastly, we also provide a lot of education on the most appropriate and structured plan for incorporating exercise into your daily life. So you've probably heard or will continue to hear today just about how important exercise is when you're living with Parkinson's. It's not only important just for all of us anyways, but especially for PD. And it can be overwhelming. There's so many great programs and great resources out there, but a question I get a lot is like, how do I know what I'm supposed to be doing and how much I'm supposed to be doing every day? And is this type of exercise better than this? So we can take those times in those PT sessions to really talk about what's the most beneficial for you as an individual based on what you enjoy, or what kind of other conditions you might be experiencing. Have you had a recent knee replacement? Things like that. So in addition to maybe torturing you through some exercises, because we get that reputation, we also provide a lot of education for you and your family. Which leads me to touch on why is exercise so important and why should you see a physical therapist. And even if, I have to preface too, even if you are very early on in your journey with Parkinson's and you're not feeling like you're having a lot of symptoms, I really encourage you to see a physical therapist as soon as possible and really develop that relationship with us so that we can be a piece of that puzzle with you along with the other members of your care team throughout your journey with the disease. And the reason exercise is so important is because it truly is medicine when you're living with PD. The research just keeps showing, year after year, more robust evidence about how exercise is so beneficial when you're living with Parkinson's. So in addition to all the other health benefits from exercise that we know, it's good for your heart and your lungs and your joints, your muscles, and all of those great things, we also know that it can really make a difference on the motor symptoms of Parkinson's. So exercise can decrease rigidity that you may experience. It can improve bradykinesia, or that slowness of movement. It can help with balance, coordination, gait impairments, challenges you're having with walking, and reduce your risk of falls. So that's just the tip of the iceberg, but those are some really important things that people with Parkinson's face. And what's the most encouraging and really significant is that research is showing that exercise really can make a difference at the level of the brain and potentially slow the progression of Parkinson's disease, which is wonderful. And so it's not only that we're just promoting exercise because we're just saying, it's good for you because it's what I do and I have to, preach what I practice as a PT, but no, we really know that this is changing the level of the disease process at the brain. And it can not only improve motor symptoms, but exercise can also improve your mood, your cognition, your motivation, and ultimately all those things put together really improve your overall quality of life. So just to touch on, I could go on forever about the things and interventions and things that we do in physical therapy directed towards Parkinson's, but I'm just going to touch on a few of the really big ones. And so one thing that you might experience or hear a term of when coming to PT for Parkinson's is forced intensity exercise. And what that means is exercise that's at an intensity that's not self-selected. So it's controlled by an outside force, meaning instead of getting on a bicycle and just pedaling at a leisurely self-selected rate, it's somebody really pushing you to keep up a certain RPMs. Or it might mean getting on a treadmill and instead of walking at your own comfortable speed, it might be that evil PT over there cranking up the speed and making you walk a lot faster than you think you can or should. And the reason why forced intensity exercise is so important is that research shows that there is a strong neuroprotective benefit on the brain with that higher intensity exercise. So, it can really help slow the loss of the neurons and slow the disease progression. But that is why you need a skilled physical therapist who understands that concept and understands Parkinson's disease to know how to make that individualized for you to make sure that it's safe and dosed properly. Some other programs or interventions that may be incorporated into physical therapy are under the umbrella of amplitude and functional movement training. And these may be things you've heard about, such as LSVT Big, or what's a progression from that program is called POWER, which stands for Parkinson Wellness Recovery. And these two programs are really all about exercising in various functional positions, meaning seated, standing, on the floor, on your back, on your stomach, on hands and knees even. And there's an emphasis on high effort and high amplitude movements. And that's important because it really helps specifically target skills that often interfere with mobility for people with Parkinson's disease. So those programs are often incorporated into physical therapy sessions and then often given as a home program or have group classes in the community, such as through Michigan Parkinson Foundation or places like the Recovery Project, where they have weekly classes where you can keep those up even when you're not in physical therapy. And then rock steady boxing is another common one you might hear about. And rock steady boxing is not putting two of you together in a ring to box each other, so just want to be clear. It's a non-contact boxing-based curriculum, and it's a great program that is often incorporated into physical therapy or occupational therapy and then transition into a group class format. And it really addresses many symptoms of Parkinson's disease through that curriculum. It incorporates agility, strength, speed, endurance, hand-eye coordination, footwork, cardiovascular training, a whole host of different skills that translate really well to what many individuals with Parkinson's are finding challenging due to the disease. So those are just a few. Like I said, there's a lot of other things that we work on and that we can tailor. Like, for example, if you're having other vestibular issues or visual issues, there's a lot of other things we can incorporate into treatment based on your one-on-one evaluation with a physical therapist. But in general, it's really important to remember that a neurological physical therapist is a really important member of your comprehensive care team, and to really seek out someone who has experience working with individuals with Parkinson's disease. And that developing that relationship and seeing your PT yearly at minimum is an important piece of your overall care plan, and should be thought of in the same way that you see your primary care physician yearly, to help you address and monitor any changes. So we do really comprehensive assessments, and then what's nice is we can compare that year over year and say, well, we noticed maybe your balance score is sliding back a little. Let's do a little kind of tune-up, or let's update your home program a little bit. And we're really here to, like I said, it's not only pain and torture, but to support and educate and guide you, so you can really maintain your greatest quality of life and independence, and really live your life over Parkinson's disease. So that's all I have on physical therapy. I'm going to turn it over to my colleagues here.
Hi, good morning. The other Brian Cooper couldn't make it in today, so they found me walking through the lobby there, and they said, hey, would you mind? So yes, I am actually Brian Cooper. We were laughing about how that picture got put in there somehow. That's not me. I haven't changed that much. I did shave my hair, so having hair is a new thing for me since 1996. So I'm an occupational therapist. I work with residential home health. I've been with residential for 15 years come June. I started my career in acute care setting in St. John Hospital, Mac and Ross, back in Detroit, Grosse Pointe border. After a couple of years there, I've been practicing for 21 years now. After a couple of years, I got kind of roped into helping the Michigan Parkinson's Foundation out, and ever since then, I've been involved in one way or another, helping either organize runs or second opinion clinics or doing different things here and there. My background also, aside from that, I was trained at the first LSVT Big. So LSVT Big, the first one out in California that they did the training. And then I was trained in Parkinson's wellness recovery as well, so POWER. So I do have a little bit of experience in that. Other than that, my job is, I am an occupational therapist. I'll ask if anybody has had an experience with an occupational therapist, if you can raise your hand for me. I'm just curious. Good, that's actually more than I was expecting. Right now I do work in home care. So all of my visits are for people that are homebound. It's been a really good opportunity to see somebody go through the progression of Parkinson's disease to make sure that we focus on what my job is as an occupational therapist. And my profession, unfortunately, has the worst name in the world, because I call people, they're like, well, I don't need a job. I don't work anymore. And I said, well, I'm not necessarily here to help you get a job. And then secondly, they say, well, I can put my own socks on. And I'm like, well, I like to think that there's more to me than just putting your socks on. So if that's what your interpretation is, I get it. Because again, we don't have a great name discipline. My job as an occupational therapist is to help whoever I'm working with maintain their independence and their safety at home. So that's what I do in home care. You'll know, if you've had Parkinson's for a while, that life gets a little bit more complicated as you go through the process. Dressing yourself might take a little bit longer, getting yourself to the bathroom, managing buttons, zippers, different things like that. So we're all encompassing in a sense that my job is to make sure, again, that you're doing everything that you want to do for as long as you can throughout this process of Parkinson's disease. So in the home setting, what we work on is dressing, making sure that you can bathe yourself independently and safely. I focus a lot on fall prevention, caregiver education, making sure that they understand how to help somebody with mobility and transfers so that we can keep them at home and safe. Fall recovery, getting up and down from the floor. I do a lot of fun things. We moved from the city. I lived many years on the east side. One day I came home, my wife said, we're moving to Metamora, and I said, okay, That's a little bit different if you guys don't know. So we went from the city living to a country rural setting. What I learned real quickly is that there was a difference in the population, and I'm not picking on city people, but my country folks are tough. They're hard workers, and they want to do things. They want to be on their tractors and plow their fields and do things like that. So it's been a really good experience for me to see both sides of that. So there's been plenty of times when I'm working with somebody at home, and they said, Brian, I still want to be able to get out and get back on my tractor. So as an occupational therapist, we incorporate it to our plan of care, is to be able to get back out to their barns and do things like that and work on the projects that they want to work on. We do a lot with exercise-based as well. When you're managing somebody with Parkinson's disease, you're trying to manage the challenges, like the rigidity, the stiffness, the decreased amplitude of movement. We're addressing fine motor coordination so that you can manage the zippers and the buttons and toilet yourself in a timely manner so that it's not frustrating or challenging. We talk about adaptations for making sure mealtime is something still pleasurable. I find great pleasure in eating, and sometimes that can be stressful for somebody that has Parkinson's to be able to go out to a restaurant and feel comfortable, sitting down in a chair, getting to it safely, making sure that you can manage the shuffling and gait freezing. And then when you get in that seat, that you're in a good position to safely feed yourself and be able to manage the utensils and not feel uncomfortable. So we talk about how you can be independent again with that, whether it's through adaptations to the utensils, addressing posture when you're sitting in the chair, going over all of that stuff. One of the biggest things that I like to address in the home setting is one of the biggest challenges I think for Parkinson's is that's getting into and out of the bed. I don't know if you guys realize this, but there's a lot of times at night that you'll have to get up and use the bathroom, and that's a little bit complex when you have Parkinson's. I always say people with Parkinson's, they lay where they land, and you see people when they get into bed that they're kind of hugging that corner of the bed, and I think sometimes it's helpful because you can use the rigidity to your advantage. When you go to get out, you just drop your legs over the edge and you start kind of pulling yourself up into a sitting position. So we talk about being able to be quick and successful in bed mobility. We talk about adaptations, adding bed canes and different things to help you get up and down, and then get yourself into the bathroom in a timely manner. I think it's really important because I value sleep. I have 4 children. They're getting older now and we sleep more, but the fact is that I think once you're in bed, I want you to be comfortable and sleep well so that you can function well the next day. And we know with Parkinson's, one of the biggest challenges you guys experience is fatigue. You always feel tired. And, huh? Yeah, and you might not be getting great sleep at night. So I want you to be able to get into bed, and not only be able to get into bed, but reposition in bed, which means rolling. A lot of us don't lay in the same position all night long, so you like to roll onto your side. For somebody that has Parkinson's, it's very challenging to reposition. So we incorporate the concepts of the exercise protocol, the increased amplitude movement to teach you how to roll and reposition, and not only that, be able to manage your sheets and blanket so that you can get out. And I'm sure none of you have ever felt like when you were getting up from the bed that you were attached to it like Velcro, right? So you're trying to slide and you're not going anywhere. That's classic Parkinson's stuff. So we teach, again, how to incorporate the concept of some of those exercise movements to teach you to function better and be able to get out of the bed and be independent. So that's a big thing. I teach a lot on incontinence management. Incontinence is a big factor in people falling, so we talk a lot about that. And incontinence can be quite challenging too, in a sense of it's a frustration for the care partner, if you will. So a lot of times I hear that somebody with Parkinson's, they might go to the bathroom 2 or 3 or 4 times during the day, but at night it seems to be almost every hour. That doesn't ring true for anybody, right? Sounds familiar? So we teach about what we can do for that, and there are strategies that we can use to, help encourage activity throughout the day to manage fluid and edema, and ankle pumps from the physical therapist. Those are for a reason, and elevation. So we talk about that, and then talk about strategies to successfully toilet yourself at night. So much so that sometimes we have to have the care partner. I was experiencing one situation where the wife's like, Brian, I'm gonna get rid of him pretty soon, because I get up 4 times a night to take him into the bathroom, and it takes him 20 minutes to get there. So quick math will tell you that's an hour and 20 minutes of not pleasurable time that compromises their relationship. So we talked about strategies to manage that, using a urinal. We put a handrail next to his bed so he can stand up and hold that while she helped take care of that, okay? And then got him right back into bed. So that's my job as an occupational therapist, is to address all of your challenges, everything, dressing, bathing, household tasks, doing your laundry, getting out to your tractor, working in your barn, doing leisure activities that you enjoy, trying to talk about ways to adapt that and make it safe. If ever you have the opportunity to have an OT come into your home, it's a great opportunity to talk about aging in place and do a home safety assessment and make recommendations for this process throughout the process. So when I hear somebody's adapting their home, I'm like, it would be a great time to have an occupational therapist come out and make sure that you're gonna make changes not only for today, but for a couple years down the road too, because you don't want to keep doing those adaptations to the home. Sorry, can you hear me or? Yeah, I think, occupational therapists practice in an outpatient setting. I think, do you guys have OTs so I think with the Recovery Project, they have OTs and they can do home visits based on different insurances, I believe, but there should be some OTs that can work with you in an outpatient setting and talk about changes at home. So that, again, I hope that's kind of a brief overview of what we do. Did I miss anything? Sound all right? And I can't advocate, honestly, in preparing for AnnMarie to come up, I can't advocate enough as an occupational therapist for a speech therapist, and she's going to tell you why, because I think they're critically important for somebody that has Parkinson's. So thank you, guys. Yeah.
All right, I'm the last one before we eat, so I'll try to keep it brief, try to keep everybody ready to go. I'm sure everybody's ready for a break. It's been a very productive and hopefully informative morning for everyone. My name is AnnMarie Bates, and I am a speech-language pathology clinical educator at Central Michigan University in Mount Pleasant, Michigan. And everywhere I go, I have to say, fire up chips. So you guys can report to Dr. Davies that I did that. I saw some people with their arms up, yes. So as a speech pathologist, you will notice that we treat primarily persons living with Parkinson's from the shoulders up. And the areas we primarily treat are speech and language, swallowing, and some cognition. I'm going to talk about all three a little bit differently and what we do for those. First is speech. And what happens when you're living with Parkinson's is 90% of the Parkinson's population develops dysarthria of speech. Dysarthria of speech is a motor speech disorder, and it primarily impacts loudness, rate, prosody. So people maybe will notice they have a more monotone vocal quality. They don't have as much emotion in their voice. They may be speaking much more quickly than they have in the past. And they're not speaking as loudly as they have in the past. Although what I have learned is from my patients with Parkinson's, quite often they think it's their caregiver whose hearing is going. All the time. Okay, I have some people that are raising their hand. Okay. So on that note, I'm going to advocate for audiologists as well. Not only for the person who is living with Parkinson's, because it's hard to know how loud your voice is due to your Parkinson's diagnosis, but also if you're possibly having a hearing loss. But caregivers, feel free to get your hearing checked as well, okay? That happens a lot. And really, it's because the person living with Parkinson's just doesn't realize they're talking the same as they always have. They're not changing anything. We're the ones that are noticing a difference. And it's hard for us to say we're noticing a difference, and we think maybe some intervention would help. There are two primary types of therapy. There's a lot of different therapies to treat people that are living with Parkinson's and their speech. Two of the primary ones are LSVT Loud and Parkinson Voice Project Speak Out. Both of these are very similar. And what you learn through both of these programs is to speak in a way that initially doesn't necessarily feel natural, to project your voice, to speak louder, to use intent so that other people can understand you. We have a virtual group on Friday mornings through the Michigan Parkinson Foundation, and I'm telling people all the time, most everybody's in the Detroit area, project your voice to me in Mount Pleasant. Pretend you're at a football stadium. Whatever you need to do, project your voice. Speak with intent, speak more loudly. What needs to happen with these programs is there's an evaluation to determine if these programs would best meet your needs. To see, again, we will check your hearing whether you want to or not, maybe send you to an audiologist. And then we teach you exercises to maintain your speech as long as possible. And it's never too early to start these programs. I have people who have called and said, I was just diagnosed. I don't know if I'm ready for this. Get started. We will provide you with a home program that's twice a day, and we will ask you to do that twice a day on your own or with a caregiver to really maintain the current speech functioning that you're having at that time. It's also important, one main difference right now between LSVT Loud and Parkinson Voice Project is Parkinson Voice Project does advocate for weekly speak out groups, and it becomes a support group. Yes, it's the exercises for your speech, it's to make sure that you're speaking loudly and more clearly, but it's really becomes a support group. One of our members quite frequently says, I found on those number exercises, I like to challenge myself and do this. And we're like, oh, tell us about it. We're able to share that information and that experience as well. As your Parkinson's continues to progress, we do have you often come back in for checkups. Do we need to help you expand on what you've been doing? Do we need to change your home programs up? What do we need to do? We also, as well as what we've heard from PT and OT, we do provide education as well. This is where you're at. This is what you should do. This is how we can keep your voice strong and healthy and intentional. For dysarthria, not dysarthria, I'm moving on to my other part. For swallowing problems, often called dysphagia. Has anybody noticed difficulty swallowing as they've been diagnosed? Okay. We're all getting ready to sit down to a meal. Eating is a very big quality of life concern for everyone. It's social. We like to have meals and go to restaurants with family and friends. And when we start to have difficulty swallowing, that becomes a concern. What happens in Parkinson's with swallowing is that, again, you're not moving the muscles, the anatomy, your larynx well when you're swallowing, and you risk penetrating or aspirating into your larynx and your lungs. Penetration is when food or liquid might actually kind of fall into your laryngeal vestibule. I hate to use that word, but your larynx, okay? I'll use voice box. And you might cough and then kick that back out and it'll go into your esophagus towards your stomach as it should. Aspiration is when the food and liquid actually go into your lungs. And if that happens, it can cause pneumonia. And when you're already living with Parkinson's, nobody needs something else that they need to fight, and nobody needs to battle pneumonia. So again, I really recommend, as soon as you have a diagnosis of Parkinson's, to have a speech therapy evaluation, check your swallowing function. We don't have x-ray vision, so we can't tell if anything is going toward your lungs unless we sometimes do some additional evaluations, such as a modified barium swallow study. If anybody's had a barium swallow study in the past, it's very similar, but we just look at your neck region as you're swallowing to make sure food and liquid is doing what it's supposed to do. If we find out that this is something that is an area of concern for you, we can provide, again, intervention specifically in that area. And the other thing that we can do is maybe teach you some strategies to keep you safe when you're eating. Some people, we might ask them to tuck their chin. We might ask them to maybe use what's called an effortful swallow, where every time you swallow really hard and you think about it. And now everybody's going to do that in the next few minutes, and that's okay. But to think about it and really use effort and be intentional about swallowing to make sure that you're safe when you're eating. Both of these are really important in combination to think about because as you're living with Parkinson's, we want to make sure we hear your voice. We want to make sure that we are able to hear what you would like to happen as you progress. And sometimes that makes, you might make decisions about swallowing, whether you want your diet changed, whether you want to maybe change your nutritional options. But we want to make sure that you are communicating well enough to tell us the choices that you would like to make. Last is cognition. As can happen with Parkinson's, is you may start to notice some memory loss, some difficulty thinking about things, and that's another area that we can provide intervention with as well. I'm not going to go into that as much today, but just know that that is another area where if you're noticing some of those changes, you can seek out a speech pathologist, have an evaluation completed, and start some intervention in that area as well. I want to follow up with what was said earlier today. Every member of your care team is a critical member of your care team, and hopefully they can work together to best meet the needs of you, your family, and your caregivers as you live with Parkinson's. Thank you so much for your attention. I've appreciated being here today.
Stay for questions for a minute? Okay, here, I can even bring the Okay, this is on. So if you have questions, just raise your hand and I will come around to you. Gwen, I see ya. I'm coming to you first.
Thank you. I'm pretty loud myself. Okay. I get calls, I don't understand why, from people from all over the United States that have Parkinson's. And one of the first things I ask them is, do you have your care team in order? And they'll say, what? Huh? A care team. And in our group, I always provide this list to new members, and I reinforce with our older members. Look at your care team. It is so important. But get this is the thing. People don't know because neurologists, with their first contact, doesn't explain it to them. I get new onset, young onset individuals that say, well, you know, I'm 27, I don't need to exercise, I don't need to talk to a PT, but you need to start as soon as you can with your PT. The other problem, someone asked about insurance. Now, I wasn't prepared to present this, so I don't have the exact details, but not years ago, but about 6 years, 7 years ago, one of the Levins, Sandy Levin, I believe, put into place a bill under Medicare that individuals with Parkinson's can have ongoing physical therapy. So, this is the thing. Who knows this, right? Nobody. So, but that's right, me. So when you're in a care facility and they say, oh, your physical therapy is run out, you have to go home, and you have a little information, just a little, and you say, well, you know what, I understand it's a bill that says we can have ongoing physical therapy, any information, and your world changes immediately. Because physicians, they're used to telling you, you are the receiver. You know, they are the giver, you are the receiver. They have 20 minutes to talk to you nowadays and you're out the office. But so I hope that helped you with your information with insurance, because insurance is different today. You know, before you get a packet, this is what you have. Now every day it changes. And one of the things I add in my list, and I need to make this short, I'm sorry, is insurance. Have an insurance contact person, a person that has some common sense, because it's different after COVID. Every time you talk to someone, they know something different. So your care team, let me get back to the point and give this mic away, because I can talk about this forever.
That's okay. No, that's okay. I was just going to see if Meghan wanted to weigh in on anything there.
I would just say that can you hear me okay? Is this on? Okay. I would say, you know, it's everybody's insurance, as far as the insurance question, everybody's insurance is different, and it is so complicated and so hard for the average person to, you know, figure all of that out. So what I would recommend is, if you know of a place you want to go for PT, OT, or speech for therapy services, they can always get all of that, your information, and then give you all sorts of guidelines about what your policy entails and how many visits you're allowed, and, you know, that kind of thing. But the biggest thing too is to know that, you know, when we are seeing you in therapy, the goal is not to have you be dependent on staying in therapy forever. The goal is to really give you the tools and the resources that you need to continue to be able to do the things you want to do safely. And then, like we said, come back and see us if things change or if you need a little tune-up. So that's really our goal, is to kind of be your coach and supporter and leader in that. And then hopefully you'll get to a point where you don't even need us or want to come see us. So that's what I'd say.
Absolutely. And thank you, Meghan. And thank you, Gwen, for advocating on that. That's a really important topic. Does anyone else have? Oh, yep.
Yeah, well, I agree that the team approach is really nice, but, you know, I've talked to some of my team members and they don't communicate. And it's almost like I have a full-time job. It's a good thing I'm retired. Because between health insurances and trying to get professionals to communicate, I don't feel like the team approach is really happening too good, at least not for me. I get, kind of tired when they will say, well, if they're not in our facility, then we don't talk. And so then I said, well, what about the patient portal? Well, you're responsible for that, so go ahead and use the portal. So I don't know, I just get fed up kind of with all the stuff I have to do, but I guess if it's going to help me be stronger, that's good. But I just wanted to say that because I've asked my team to communicate, and they haven't done it yet. So.
Any suggestions?
Yeah, so I had the good fortune of being part of and it was the Michigan Parkinson's Foundation was helpful in supporting us too with the PD Self program, which is the Parkinson's disease it was called the self-efficacy program, okay? So I think part of what you're talking about is a trend in what we see in healthcare in general. So part of our job in that program, and part of my job as a healthcare professional in the home health, is that I teach self-efficacy and self-management, which means I have to empower you to feel comfortable asking questions and really kind of grabbing the bull by the horns and initiating those conversations. So when you have that information, you take it to them to present it to them. It's a bummer that you have to do that because it would be great if everybody had time to kind of case conference and team meet about you. But the best thing that you can do for yourself is always self-advocate. And I think that's so critical, and we want to teach you how to feel comfortable doing that. So I would say as much as you can empower yourself to have that education, take your folder, take your top 3. I always like saying take your top 3 questions because like we talked about, they're short on time. But if you have your 3 questions, you can dictate the conversation and how that appointment will go versus just like getting kind of panicking or freezing up and not asking your questions. So it sounds like you're doing a great job of that. I would encourage you all to feel empowered to ask questions and really kind of understand your disease process and again, speak up on your own behalf because if not, I worry that a lot of people will get overlooked. So that's great.
And I think this is where a lot of you care partners are doing a great job too. I think 2 people in every appointment is a wonderful thing, just to catch some of those questions that you forgot to ask or weren't aware of, or to hear something that you might have missed. Okay, there was another one. Okay.
And the doctor put the script together, and then the problem was that they come over, they walk through the door, they have machines, they fill out these machines, they're there for 45 minutes, they walk out the door, and they're nice people, but they don't, who do we call to correct this? Who do you saying contact your care? Who do we contact?
Was the question that they're not allocating enough time to you?
No,
Is that, I guess I didn't hear.
No, the question is, who do you contact when you
Oh.
want to have? If I want an OT or I want a PT.
So if you want a referral to home care, when you go to see your neurologist or your primary care physician, let them know that you have an interest in having home care ordered, and they can go ahead and send that script into the home care agency, and they'll initiate that process for you.
Okay, thank you.
Yep.
All right.
I just want to make a comment, and I'm only 6 months into this, so I'm new. But one thing that I know is that I have to drive my own bus. It's up to me to manage my care team, and my care team have seats on the bus, but I have to drive it. I have to educate myself, I have to advocate for myself, and I have to do what the doctors tell me, but I can't sit by and wait for them to run my show for me.
Yeah, very good point. Yeah.
I'm grateful that you do what you do, but how do we find you? Because I've looked on, online with the LSVT or the recovery program. I've looked for therapists that are trained in Parkinson's, and I get nowhere. When I call different facilities, they'll say, well, we don't really have that, or we have one, and I just find it really difficult to find you.
Sure. Yeah, I'll give a plug for Michigan Parkinson
I
Foundation.
was just
Sorry,
going to say. No, go ahead.
Anyone I talk to who's newly diagnosed or just newly reaching out for resources, I always tell them to go to the Michigan Parkinson Foundation website first, because they are just a wealth of information. They have all sorts of headings on their website if you're looking for exercise classes or therapy providers and support groups, all of that information. So, that's the first place I tell people to go. That's another reason why it's important to have a movement disorder specialist on your team, because if they are treating people with Parkinson's, they are referring people usually very regularly to therapy and know trusted providers that they can send you to. And you're right, in addition, if you're interested in particular programs like Power or LSVT, there's usually a directory on their website where you can search for a certified provider. Oh, yeah, that might be the
and
case.
I'm just going to say, yes, please call Michigan Parkinson Foundation. If you can't find it on our website, or if you can't find it elsewhere on other websites, we take the time to talk to you and hear about your individual situation, and then we'll send you a comprehensive list of, this is what we talked about. So for speech therapy, this is, a couple places you can decide, but here are a couple places that we often refer to. We have just a whole list that we send people, but yeah, this is exactly why we're here and why we're doing this presentation. I will also let you know that last night we met with 40 movement disorder neurologists from around the state. And our big push in talking to them was, how can we help your patients more? How can we get into your system, your patient portal, so that you have resources to let people know who to call when they leave your office? Sorry, so we have time for just probably 2 more questions, and I see a hand up over here. Okay, got it. Okay.
Just some quick information before everything gets away from us today. My husband obviously has Parkinson's, and we have had help money-wise from the Michigan Parkinson's Foundation. But there's also a foundation called the Assistance Fund. And if you call that number, Parkinson's is one of the things that's on their list, and he gets 90% of his meds all paid for through the Assistance Fund, 0 copay. One of his meds is $1,200 a month. The other one is about $2,000 a month, and they're paid for.
And they don't base it on income or anything like that, or wealth or whatnot. They just look at you as another.
Yep, just look at you, and if that disease is on the list, it's covered. So call the Assistance Fund if you need help with your meds.
And in addition to that, just where respite is concerned, if cognitive issues ever, at the point that you might need respite care assistance, if that becomes an issue, we refer directly to the Alzheimer's Association as well, where you can get additional funding. Okay, so I'm sorry, time for one more question. Okay, okay, we'll do 2 more. We'll do 2 more.
I wanted to ask about the medical authorizations. Because sometimes when I have medications, they don't want to pay for them. Okay. And I would like to know, when is it necessary, or how do you access medical authorizations after they deny them?
Okay. For just assistance reimbursement, medication reimbursement? It's about medication reimbursement. With medical authorization. Okay, that part's, I'm not sure. Medical authorization for PT, OT, or speech? Is that, and medication as well? Okay, maybe we can talk separately on this one. Does that sound good? Okay, I'll circle back to you in just a minute. Okay, we'll take it over to this gentleman over here, and then we're gonna wrap up right before lunch.
Hi, my question is for the speech therapy. At the end of your talk, you said something about cognitive. I didn't understand exactly what you meant. Could you repeat it, please? Cognitive therapy. Yes. What does it mean? When do you need it? What do you do about it?
When cognition is a concern for you?
Yes.
Okay, when cognition is a concern, what do you do?
Okay, so if cognition is a concern, first of all, hopefully you've already mentioned that to your doctor to ensure that that's being managed as it should be. But your next step would then, if you wanted to pursue intervention, would be to have your physician write a script for speech therapy. And then when you would come in, we would administer an evaluation to determine exactly what areas of cognition you're noticing a change in. We provide intervention then to hopefully provide you with strategies. So what can you do if you're forgetting things? What strategies can we put in place? What maybe visual supports can we put in place so that you remember what you need to do? But we can also provide specific intervention, and it needs to be tailored to each individual. So I can't answer exactly what we would do for everybody. But there would be techniques and strategies and intervention that we would put in place to target your areas of need. Does that answer your question? Okay, thank you.
All right, AnnMarie, Brian, Meghan, thank you so much for sitting on this panel. And it looks like they're starting to bring lunch out, so enjoy the lunch hour. We'll be coming in with a couple announcements, but enjoy some social time and lunch as well.